Okay, let's dive right into a true life-threatening emergency. If you're preparing for your boards or getting ready to hit the wards, this is a massive exam favorite. Welcome to this explainer on pulmonary edema, cardiogenic versus non-cardiogenic mastery. We're going to break down exactly what happens when the lungs fill up with fluid, how to figure out the root cause instantly, and precisely what you need to do to save your patient.
So, picture this. The emergency room doors swing open and you've got a patient presenting with these absolutely terrifying acute symptoms. They're gasping for breath, they're coughing up this unmistakable pink, frothy sputum, and when you put your stethoscope to their chest, you hear coarse crackles all over the lung fields. So here's a quick Socratic question for you. Is this patient's heart failing, or are the lungs themselves fundamentally damaged? That's the ultimate puzzle we're solving today.
Here's our clinical roadmap for the explainer. We'll start with the gasping patient, then look at pressure versus permeability, move into gathering the clinical clues, cover emergency management and rescue, and wrap up with a high-yield exam review.
All right, part 1, the gasping patient. Let's look at the definition and features. The core concept here is physically simple, but physiologically deadly. Pulmonary edema is just the accumulation of fluid right where it absolutely shouldn't be, in the interstitium and the alveoli, those tiny air sacs in the lungs. When fluid fills the alveoli, it creates a physical barrier that completely blocks oxygenation. The lungs just can't exchange gas, and this rapidly leads to hypoxia. Basically, your patient is drowning from the inside out.
Because of that fluid barrier, when you're gathering the history, you're going to see a classic constellation of symptoms. You're looking for sudden dyspnea, or shortness of breath, and orthopnea, which is shortness of breath that gets significantly worse when the patient lies flat. You might also hear about paroxysmal nocturnal dyspnea. That's waking up suddenly, gasping for air in the middle of the night. But the absolute golden exam giveaway, the pink, frothy sputum. The froth comes from air mixing with fluid, and that pink tint is from red blood cells actually leaking into the alveoli. In really severe cases, you'll even see cyanosis from profound oxygen starvation.
Let's move on to part 2, pressure versus permeability, cardiogenic versus non-cardiogenic.
This dichotomy is great because it simplifies everything into a logical battle of starling forces. Either fluid is being pushed out of the blood vessels because the pressure is way too high, or fluid is leaking out because the vessel walls are actually broken. You really want to remember this refrain. If it's a pressure problem, specifically increased hydrostatic pressure, it's cardiogenic. The pump is failing. But if it's a permeability problem caused by alveolar capillary membrane damage, well, that's non-cardiogenic. The pipes are leaky.
Let's look at the pressure side first. Left ventricular failure is the absolute star of the show here, and it's the most common cause you're going to see. When the left ventricle fails to pump blood efficiently out to the rest of the body, that blood backs up. It goes into the left atrium and then directly into the pulmonary veins. This skyrocketing hydrostatic pressure literally squeezes fluid right out of the capillaries and into the lung tissue. Mitral valve disease and general fluid overload, they do the exact same thing. They just spike the pressure. Now flip the script to the permeability side. Here, the pressure might be totally normal. Instead, you want to think of conditions that cause direct or indirect damage to that alveolar capillary membrane. ARDS, or acute respiratory distress syndrome, is your classic example here. But sepsis, massive trauma, and even high-altitude pulmonary edema, or HAPE, can compromise that delicate membrane. The physical barrier just breaks down and fluid floods right in.
Okay, section 3. Gathering the clinical clues.
This table right here, it's literally your ultimate cheat sheet for telling these two apart. Look straight at the lab values and pressures. You've got BNP, brain natriuretic peptide, and PCWP, pulmonary capillary wedge pressure. If these are elevated, you are dealing with a failing heart, hands down, because these markers spike when the heart muscle is stretched out and under high pressure. If the BNP and PCWP are totally normal, but the lungs are still full of fluid, you're dealing with a non-cardiogenic permeability issue, like ARDS.
Even the chest X-ray basically hands you the diagnosis. Here is a massive pearl for your exams. If a question vignette describes a bat wing appearance, which is this central symmetrical cloudiness radiating from the hyla, or if it mentions curly B lines, which are these tiny horizontal lines at the lung bases showing interstitial fluid, just mark cardiogenic and move on. Non-cardiogenic edema, on the other hand, usually shows up with patchy, diffuse infiltrates all over the place, totally missing that classic cardiac shape. Section 4, Emergency Management and Rescue. These are your must-know steps.
For acute cardiogenic pulmonary edema, you absolutely have to have the LMNOP mnemonic down cold. It's your immediate, life-saving game plan for clearing that fluid and dropping the pressure. L is for Lasix, or furosemide, a powerful diuretic to help them dump that excess fluid. M is for morphine, which reduces anxiety and actually causes venodilation to decrease preload. N is for nitrates to aggressively vasodilate and take the workload off the failing heart. O is for oxygen to fight the hypoxia. And P is for position. You want to sit the patient completely upright. Like gravity, pull that fluid down to the bases of the lungs so you can free up the upper areas for gas exchange.
Beyond the LMNOP sequence, you might need to bring in non-invasive ventilation, like CPAP or BiPAP. The goal there is to literally push the fluid out of the alveoli using positive pressure. And of course, you have to treat the underlying cause, whether they're having a heart attack or they're in sepsis. Why the extreme urgency? Because if you leave this untreated, this progressive hypoxia is a one-way ticket to complete respiratory failure, massive organ damage, and ultimately death. Time is tissue here. Finally, Section 5, High-Yield Exam Review. Let's do a rapid revision.
Number 1, always remember your leading overall culprit. If you're asked for the most common cause, it's the left ventricle giving out and causing that pressure backup.
Number 2, word association is everything. The second you hear or read the words pink frothy sputum, boom, your mind should jump straight to pulmonary edema. There's just no other condition quite like it.
Number 3, on imaging, that classic symmetrical batwing X-ray pattern firmly locks you into a cardiogenic diagnosis. Number 4, an elevated BNP is the critical lab value that proves the heart is stretched, stressed, and is definitely the source of your pressure problem.
And number 5, if a scenario describes massive inflammation, totally normal cardiac pressures, and diffuse fluid, ARDS is your classic non-cardiogenic permeability-driven disaster.
So whenever you face this, ask yourself, is it pressure or permeability? Is the BNP high or normal? What's the X-ray pattern? Master those 3 things and you'll crack the case every time. But here's a thought I want to leave you with. What happens when a patient arrives with a failing heart and a massive lung infection at the exact same time? How do you treat the pressure when the pipes are already broken? Keep thinking critically, and thanks for joining me on this explainer.